Hello everyone. Now we are going to discuss about the chronic leukemias, which include the chronic myeloid leukemia and the chronic lymphocytic leukemia. Let us discuss about the chronic myeloid leukemia. It is a myeloproliferative disorder caused by the exposure to the radiation or the chromosome 922 translocation. The ABL gene is present on the chromosome 9, which is required for the multiplication of the cells, and the BCR gene, which is also known as the breakpoint cluster gene, it is present on the chromosome number 22. In CML, the ABL gene is translocated to the chromosome 22, which leads to formation of BCR ABL gene fusion. This is also known as the Philadelphia chromosome. This fusion gene leads to the increased tyrosine kinase activity, which causes increased replication of either of the three cell lines, the mostly WBCs, and then the platelets. This fusion gene also leads to the decreased apoptosis. The high risk age group belongs to the 25 to 60 years. In the untreated patients of the CML passes through the three phases. 50% of the patients passes through the three phases, which is the chronic phase, which leads to the accelerated phase, and which leads to the blast phase. This occurs in the 50% of the patients. The CML is a slow progressive disease. In the chronic phase of the CML, which is asymptomatic, the blast cells are less than 10%. The non-specific clinical manifestations are seen. The viable period is 3 years. In the accelerated phase, we see the blast cells are 10 to 19%, and the period of the accelerated phase is 6 to 12 months. And the blast phase, we see the blast cells are more than 20%. In the other 50% of the patients, the chronic phase bypasses the accelerated phase and directly leads to the blast phase or blast crisis. In these patients, the known patient of the CML facing the sudden increase of the size of the lymph nodes are seen. The CML may also leads to the acute leukemia. It changes to the AML, which is 70%, and the ALL is 30%. The clinical features of the CML. The clinical features of the CML are non-specific. The clinical manifestations are seen, which is fatigue, weight loss, night sweats are seen. Extramedullary hematopoiesis, which occurs in the spleen, most commonly spleen, liver, and the lymph nodes, which is due to the tyrosine kinase activity. The hematopoiesis in the spleen leads to the passive splenomegaly, which causes the dragging sensation in the abdomen. Let us come to the diagnosis of the CML, in which in blood we see the increased TLC, total leukocyte count, in which we see the massive basophilia and eosinophilia are seen. In the blood picture, we see the different stages of the WBC. The leukocyte alkaline phosphatase score, which is also known as the lab score, is drastically decreased. In the bone marrow examination, we see the increased cellularity and the reticulin fibers are seen, and the sea blue histiocytes are seen, and the pseudogaucher cells are seen. And now coming to the FISH test, which is a confirmatory test for the CML, which is known as the fluorescent in situ hybridization test. Fluorescent in situ hybridization test. In this, we see the fusion gene. Here, the red color dot is an ABL gene, and the green color dot is the BCR gene. And these are the normal genes, how they appear, and this is the fusion gene, how they appear as as if they are fused. Now coming to the treatment of the CML, we use the tyrosine kinase inhibitors to treat the CML, which is imatinib. This is the prognostic index of the CML, which is known as the so-called index. In this, the S is known as the spleen size, the O is known as the percentage of the circulating blast cells, and the K is known as clonal cytogenic defects, and the A is age, and the L is the level of platelets. These make the prognostic feature. These are the prognostic features of the CML. If the spleen size is less, that gives a good prognosis, and this, if the spleen size is more, that gives the bad prognosis, like that. Now coming to the chronic lymphocytic leukemia. The chronic lymphocytic leukemia, this is it is called the CLL when the tumor cells are only involved in the blood and bone marrow, but it is also known as the small lymphocytic leukemia when the tumor cells are migrated into the lymph nodes. The CLL, it is the most common leukemia actually. It occurs in the adults and not associated with the radiation exposure, like the CML, not like the CML like this. The CML is due to the genetic mutations of the CLL, which involves the deletion of chromosome 11q, 13q, and the 17p, and the trisomy of the 12q. Additional genetic mutations are also involved: the Notch gene mutation, the somatic hypermutation, and the ZAP17 protein mutation, which helps in the mitosis signals to the cells. In the normal process, the B cells are produced, which gives plasma cells, and the antibodies are produced normally. But in the CLL, the B cells are mutated, which gives the abnormal plasma cells, and which leads to the abnormal antibody production. The mutated B cells has the increased rate of replication, which infiltrates into the bone marrow and the spleen and the lymph node. And the mutated B cells are also very fragile due to the loss of vimentin in the cell membrane. And these also produce cytokines, which are TNF alpha and the TGF beta, which finally leads to the bone marrow atrophy. The abnormal antibodies leads to the decrease in which also causes the decrease in normal levels of the normal antibodies, which gives hypogammaglobulinemia. This leads to the increased frequency of infections. This leads to the death. The common feature of the common cause of the death in these patients with CML is infections. And the autoimmune thrombocytopenia is seen, and the autoimmunity is also seen, which leads to the autoimmune hemolytic anemia. Coming to the clinical features of the CLL, which are non-specific, mostly the fever, weight loss, the more than 10% in the 6 months, lymph node enlargement are also seen. Coming to the diagnosis of the CLL, in the blood examination, the autoantibodies are formed in the blood, which gives the positive Coombs test. Both the direct and the indirect gives the positive result in the Coombs test. And the anemia is seen, decreased platelet count is seen, and the TLC is increased, lymphocytosis is drastically increased, and the absolute lymphocyte count ALC is more than 5,000 cells per microliter. And in the peripheral smear, we see the smudge cells, which are also known as basket cells or parachute cells, and intact tumor cells resembling the cells each other, but both resemble each other, or these are the tumor cells. And the smudge cells are also seen in the peripheral smear. Coming to the bone marrow examination, hypercellularity is seen, increase in lymphoid precursor cells are seen, and the myeloid cells and the erythroid cells are seen. In the lymph node examination, the biopsy of the lymph nodes shows the infiltrated tumor cells, which form the focal accumulates, which are known as the proliferation centers or the pseudofollicles. This is the diffuse infiltration. The flow cytometry, which is the investigation of the choice of the CLL. The markers CD19, 20, 21, 23, and the CD5 are positive in the CLL. In CLL, the additional mutations in the CLL, as discussed earlier, the more aggressive tumor cells, which leads to the more aggressive tumor cells, which leads to sudden enlargement of the lymph nodes and the spleen, which is also known as aggressive lymphoma or the diffuse large B-cell lymphoma. This is also known as the Richter syndrome. Coming to the prognostic factors of the CLL, the 13q deletion and the somatic mutation, if these are same, which is known as the good prognosis, it can be cured. And the 11q deletion, 17p deletion, trisomy of the 12q, the Notch mutation, ZAP17 gain of function mutation, the somatic mutation, loss of function mutation of the somatic, which gives a prognostic factor, which is a bad prognostic factor. Now coming to the treatment of the CLL, Uh, Fludarabine is a drug of choice for the CLL, and the rituximab and ibrutinib is also can be used. Thank you.